everyone, it's Schematic Med, and today we're going to talk about the initial management of acute acetaminophen overdose. Let's imagine a case. We are having our shift in the hospital, and a family comes with a child who ingested 15 tablets of Tylenol. What should we do? For our further management and to know what to do, the first question we need to ask and know is, when was the time of ingestion? If we ask this question, and they will answer it, for example, 3 hours ago. 3 hours ago. It has been 3 hours that the tablets are inside the organism. The first step is to give activated charcoal right away, which we call gastric decontamination. Our critical point marked in the middle of the page will be 4 hours, because our management differs before 4 hours and after 4 hours. One thing I want to mention is why I said 15 tablets of Tylenol. We know that Tylenol is the same as acetaminophen. 15 tablets, if we measure one tablet is 500 milligrams, equals to 7.5 grams. This is the potential toxic ingestion dose. After 4 hours, for example 6 hours, we will check the acetaminophen levels in the blood. However, even if the patient presents before 4 hours and we already gave activated charcoal, checking the acetaminophen level will be the second step. Since it takes time to get the laboratory analysis, we need to decide if we should give empiric NAC. NAC is N-acetylcysteine. We know that for acetaminophen intoxication, this is the antidote we administer. NAC will be given empirically when there is any evidence of liver injury. We know that liver injuries are indicated by elevated ALT and AST and right upper quadrant tenderness. And we give NAC if patient presents after 8 hours since ingestion, or if acetaminophen levels are still not available after 8 hours. When the acetaminophen levels come back, we need to plot the level on the Rumack-Matthew nomogram. It is a nomogram where we place the numbers we got and do the plotting. This is used to guide treatment with NAC. If the level is above the treatment line, we need to give NAC. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about management of the blunt abdominal trauma. When discussing the management of blunt abdominal trauma, we will divide the patients' groups into two major categories. Hemodynamically unstable and stable, because their management differs. Regardless of which group they fall into, the first step is always to assess for the presence of peritonitis. When we have a case with a hemodynamically unstable patient, if peritoneal signs and features are present, we will proceed to laparotomy. If peritonitis is not present, additional examination is needed, which in this case is a fast exam. Then we ask the question, do we see free fluid? If yes, a laparotomy is required. If no free fluid is seen, or if we are unsure, the next step is to resuscitate the patient and consider a CT-AP or CT scan of the abdomen and pelvis. Or another procedure which is called DPL or diagnostic peritoneal lavage, a surgical procedure performed at the bedside where a catheter is inserted into the abdomen to detect the presence of fluid or blood. Additionally, we need to evaluate for any other sources of bleeding. In a hemodynamically stable patient, if peritonitis is present, we should proceed directly to laparotomy. We can consider performing a CT-AP on the way to the operating room. If peritoneal signs are absent, the next step is to conduct a fast exam for free fluid examination. If free fluid is seen on the fast exam, we consider doing a CT-AP. If no free fluid is seen, or if we are uncertain, we consider doing a CT scan with contrast, including the abdomen and pelvis, or serial abdominal examinations. The main difference in hemodynamically stable patients is that when free fluid is seen on the fast exam, we do a CT-AP, and if we see on the fast exam free fluid in hemodynamically unstable patient, we do laparotomy. I want to ask a question. What do you think? What is the most common abdominal complication of blunt abdominal trauma? The first thing we should suspect is spleen injury, especially with evidence of hemorrhage. Thank you, bye. Hello everyone, it's Schematic Med, and today let's talk about the blood pressure targets in ischemic stroke. First, when administering thrombolytics, we always measure the patient's blood pressure beforehand. It must be 185 over 110 millimeters of mercury. If the blood pressure is elevated, we first need to lower it before administering systemic thrombolytics. After giving medication such as TPA, tissue plasminogen activator, we must closely monitor and control the blood pressure. It should remain below 180 over 105 millimeters of mercury for the next 24 hours. As you can see, the target blood pressure is slightly lower after thrombolysis, with systolic reduced by 5 millimeters of mercury and diastolic by 5 millimeters of mercury. Maintaining these levels is crucial to ensure patient safety. Now, what should we do if we cannot administer thrombolytics? This occurs when the patient presents more than 4.5 hours after symptom onset or when there are contraindications to thrombolysis. In such cases, we allow permissive hypertension. This means we permit systolic blood pressure to be less than 220 millimeters of mercury and diastolic blood pressure to be less than 120 millimeters of mercury. However, when blood pressure is extremely high, when systolic blood pressure is higher than 220 or diastolic is higher than 120 millimeters of mercury, we need to lower it carefully. The recommended approach is to reduce blood pressure by 15% within the first 24 hours. Abrupt reductions should be avoided as they can lead to further complications. For example, if systolic pressure is 220, a 50% reduction would be approximately 33 millimeters of mercury, bringing the target to 187 in the first 24 hours. Similarly, if the diastolic pressure is 120, it should be reduced to around 102 within the first 24 hours. Thank you, bye! Hello everyone, it's Schematic Math, and today we're going to talk about breast discharge evaluation. When we have normal breast examination, which is no masses, no lymphadenopathy or skin changes, and only we have discharge, we need to understand if it is physiologic or pathologic. When the discharge is bilateral, non-bloody, clear or milk-like, and yellow, brown, or gray, we suspect physiologic discharge. This can happen during pregnancy, that's why we need to do pregnancy test, and additionally we need to do galactorrhea evaluation. We need to check TSH and prolactin, and we can observe hyperprolactinemia. If we suspect that the discharge is pathologic, for example unilateral, serosanguineous, or guaiac positive, and sometimes we observe skin changes, this requires age-based diagnostic breast imaging. If the patient is less than 30 years old, sonography, we can add mammography too. If the patient is between 30 to 39 years old, we can do mammography and sonography or sonography then mammography, both of them. And if the patient is 40 years old and older, we will do mammography plus sonography. Here we have pathologic discharge, so we need to do both. So at this point, we may suspect intraductal papilloma, so that's why we need to do both. But if both mammography and sonography are negative, MRI of breast is recommended. Thank you, bye. Hello everyone, it's Schematic Math, and today we're going to talk about breast pain management. Breast pain is typically benign when it is cyclic, associated with masses, when it is bilateral and diffuse with no associated examination abnormalities, for example, a breast mass. Once again, if we have cyclic, bilateral, diffuse pain, if we have mass, we need to do imaging. But if there is no mass, we will observe, give supportive bra, and give NSAIDs, non-steroidal anti-inflammatory drugs. But if the pain is non-cyclic, unilateral, and focal, at this point we will go one step forward. It means that if we don't have any masses, we don't palpate any masses, we will do imaging. Remember when it was cyclical, bilateral, and diffuse, if no mass is present, we would just observe, but in this case, if we don't have any masses, we need to do imaging, and if the image is normal, we would just observe, but if the imaging came abnormal, we need to do biopsy. But if we have mass during non-cyclical unilateral and focal pain, we need to do straightforward biopsy and refer to breast surgeon. Here you can see I wrote about Paget disease, very high yield features, redness, ulceration, and scaling and flaking of the nipple. This is not connected to breast pain, I just wanted to mention it here. Thank you, bye. Hello everyone, it's Schematic Med and today we're going to talk about management of the CIN3. CIN means cervical infraepithelial neoplasia grade 3. This is a high-grade premalignant lesion that requires treatment with cervical conization, a type of excisional procedure. First, if the patient is not pregnant, we will do excisional procedure. For example, LEEP procedure, which is loop electrosurgical excision procedure, and we can do cold knife conization. After 6 months from the procedure, we need to do HPV-based testing. If the test comes back negative, we will do annual HPV testing for 3 years. Let's remember one thing. Conization is a surgical procedure that removes a cone-shaped piece of tissue from the cervix and will remove the entire transformation zone. That's why after conization, when we remove all the transformation zone, we never do endocervical curettage. That we will do only when we have unsatisfactory colposcopy results, for example when entire transformation zone is not visualized, or when we see atypical glandular cells on cervical cancer screening. Thank you, bye. Hello everyone, it's Schematic Med and today we're going to talk about how acetazolamide can help during high altitude illness. When surrounding partial pressure of inspired oxygen or PiO2 is decreased, peripheral chemoreceptors sense the decrease of the PaO2. PaO2 is partial pressure of oxygen, which is a measurement of the amount of oxygen dissolved in arterial blood. This leads to increase of minute ventilation and increase of PaO2, decrease of PaCO2, and increase of pH. Central chemoreceptors sense the increase of the pH and hyperventilation is stopped and increase of PaO2 is limited. If we don't give acetazolamide, renal system is excreting the HCO3 very slowly, and increase of PaO2 occurs gradually until it reaches the maximum. But when we give acetazolamide, which is carbonic anhydrase inhibitor, it increases the HCO3 excretion, which eventually will decrease the pH, and by that will improve the overall respiratory drive by not through the hypoxic pathway. It inhibits the hypoxic ventilatory response. It shifts control to central CO2 sensitivity, making the body less dependent on low oxygen as a breathing stimulus. And as a result, PaO2 increases rapidly to the plateau and PaO2 is improved. Thank you, bye. Hello everyone, it's Schematic Med and today we're going to talk about management of endometriosis. If the patient has chronic pelvic pain, dysmenorrhea, deep dyspareunia, and dyschezia, we can suspect endometriosis. We need to assess if the patient has medication contraindications. We need to give definitive diagnosis. Does the patient have infertility? And are we suspecting any malignancy or adnexal mass? If none of this is present, we will give oral contraceptives and NSAIDs. If any of this is present, we need to do laparoscopy, give diagnosis and treatment. Once again, endometriosis is initially treated with non-steroidal anti-inflammatory drugs or NSAIDs and combined oral contraceptives. Patients who fail medical therapy are recommended for laparoscopy, which can offer definitive diagnosis and treatment. Thank you, bye. Hello everyone, it's Schematic Med and today we are going to talk about functional hypothalamic amenorrhea. First, we always need to assess and manage the causes. Causes can be excessive physical training and exercises, very low caloric diet or starvation, weight loss, chronic illnesses, stressful situations and depression, and anorexia nervosa. All these will increase the ghrelin amount, MPY amount or neuropeptide Y, CRH amount, corticotropin releasing hormone amount, and GABA amount or GABA. Additionally, will increase beta endorphins. Leptin amount will be decreased. Eventually, the hypothalamus will decrease the gonadotropin releasing hormone or GnRH production, which will lead to decrease of LH and FSH production from the pituitary gland. And that we will call hypogonadotropic hypogonadism. Because decrease of LH and FSH will decrease the estrogen production from the ovaries. And that will lead to amenorrhea, decreased estrogen, bone loss, and bone density loss, and can present again with irregular menses, absence of menses, and infertility. Thank you. Bye. Hello everyone, it's Schematic Med, and today we're going to discuss the evaluation of hemoptysis. Initial management in hemoptysis involves establishing adequate patient airway, maintaining adequate ventilation and gas exchange, and ensuring hemodynamic stability. Patients should be placed with the bleeding lying in the dependent position, which is the lateral position, and bronchoscopy is the procedure of choice to identify the site and attempt early therapeutic intervention. It is very important to take history very thoroughly and do physical examination to rule out other causes, for example, bleeding from oropharynx or GI tract. If the bleeding is massive, which is more than 600 ml per 24 hours or 100 ml per hour, secure airway, breathing, and circulation. If bleeding stopped, we will do same evaluation when we do during mild and moderate bleeding, which is CBC, or complete blood count, coagulation studies, chest X-ray, renal functions or urinalysis, and rheumatological assessment if needed. After that, we will do CT with or without bronchoscopy. We will do bronchoscopy depending on imaging result and if intervention is needed. Bronchoscopy can show us the site of bleeding, and with the help of that we can do embolization or resection. We will do intervention with the help of bronchoscopy if we have massive bleeding and securing airway, breathing, and circulation did not stop the bleeding. Thank you. Bye. Hello everyone, it's Schematic Med, and today we're going to talk about how hypothyroidism can be associated with amenorrhea. Menstrual irregularities, for example irregular menses or infertility, are common in hypothyroidism. When the production of T4 or thyroxine is decreased from the thyroid gland, that will stimulate the hypothalamus, which will increase the production of TRH, or thyrotropin releasing hormone. Increased production of TRH will stimulate the anterior pituitary, which will increase the production of TSH and PRL, thyroid stimulating hormone, and prolactin. Increased amount of prolactin will cause galactorrhea. But not only that, by negative feedback, it will decrease the amount of GnRH or gonadotropin releasing hormone production from the hypothalamus. If GnRH is decreased, the anterior pituitary will decrease production of FSH and LH. And if we don't have appropriate amount of FSH and LH, we will not have ovulation and amenorrhea will occur. Therefore, typical laboratory findings include elevated prolactin and low FSH and low LH levels with low serum estradiol and low testosterone in men. Reproductive function usually normalizes with levothyroxine therapy. Thank you. Bye. Hello everyone, it's Schematic Med, and today we're going to talk about the evaluation of suspected idiopathic intracranial hypertension. Mostly, these patients will present as female during their childbearing age and with a high BMI. What will the patient first say? I have a headache, vision changes, and/or pulsatile tinnitus. We will need to ask these questions. Is your headache positional? Does it change when you change your position? This is how we assess the quality of the headache. Next, do you have any weight changes? For example, did your BMI increase? We will explain to the patient that we need to perform a neurologic examination as part of the clinical assessment. After these questions and assessment, if we suspect that the ICP or intracranial pressure is increased, we will explain that we need to perform a visual assessment. We need to assess visual acuity, fields, and fundoscopy. When I notice signs of papilledema, we need to go straight to urgent imaging, which is CT or most commonly MRI. If I suspect CVST or cerebral venous sinus thrombosis, I will consider doing venography. Even if imaging comes back negative, I'm not saying that everything is okay and that I will not do anything. It is mandatory, even if the imaging is negative, that we do a lumbar puncture. Lumbar puncture is very important. When opening pressure is higher than 250 milliliters of water and there are no signs of infection, it is likely to be idiopathic intracranial hypertension. This is how we assess and diagnose idiopathic intracranial hypertension. Once again, the MRI should always be followed by lumbar puncture, even if the MRI results are negative. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about the initial management of stroke. When a patient presents with acute stroke symptoms, the first step is of course to address the ABCs: airway, breathing, and circulation. Following this, we perform a non-contrast CT scan of the head and additional laboratory tests. The CT scan will help us to determine whether the stroke is ischemic or hemorrhagic. For ischemic stroke, we proceed with the following steps. Allow permissive hypertension to support cerebral perfusion. Administer systemic thrombolytics, for example TPA, or perform endovascular thrombectomy if appropriate. If thrombolytic therapy or thrombectomy is not suitable, we administer antiplatelet agents such as aspirin or clopidogrel. These medications help reduce the risk of early stroke recurrence. For hemorrhagic stroke, the management targets maintaining a systolic blood pressure target of 140 to 160 mm of mercury, reversing anticoagulation if indicated, monitoring and maintaining normal intracranial pressure, ICP. Using reversible and titratable antihypertensive medications such as IV nicardipine to manage elevated blood pressure. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about initial ventilator management of acute respiratory distress syndrome. Everything starts with intubation, and we need to set initial ventilator settings. The two important components of the ventilator is oxygenation and ventilation. Oxygenation is done with the help of the FiO2 or fraction of inspired oxygen, which should be 100%, and PEEP or positive end expiratory pressure, which should be 5 cm per water. And ventilation is determined by VT or tidal volume, which should be 6 milliliters per kilogram ideal body weight, and respiratory rate, which should be 14 to 18 per minute. And of course, sometimes we need to do some adjustment. We can adjust the oxygenation and we can adjust the ventilation, the parameters that we already talked about. When we need to adjust the oxygenation, we can either change FiO2 or PEEP. When a patient has hyperoxia, when PaO2, which is partial pressure of oxygen, is more than 90 mm per mercury, decrease the FiO2. If the patient has hypoxia, PaO2 is less than 60 mm per mercury, increase PEEP. This will recruit collapsed alveoli and will decrease intrapulmonary shunt. If we need to adjust the ventilation, we can change respiratory rate or tidal volume. If patient has acidosis, pH is less than 7.25 and PaCO2 is very high, we will increase respiratory rate, and at last resort we will increase tidal volume. One more time, firstly we are increasing respiratory rate. And when patient has alkalosis, pH is 7.45 and more, and PaCO2 is low, we will decrease tidal volume, we can decrease the respiratory rate, and at last resort we will increase the sedation. And lastly, let's talk about a very important point. When managing mechanical ventilation, one of the key principles is lung protective ventilation, which helps prevent alveolar overdistension and lung injury. How do we achieve this? A crucial step is evaluating lung compliance by measuring plateau pressure, P-plat. This is done using an inspiratory hold maneuver, where the ventilator is paused briefly after delivering a tidal volume. The pressure recorded at this moment reflects lung compliance and alveolar distension. The target is to keep P-plat 30 and less centimeters per water, as higher pressure increases the risk of ventilator-induced lung injury. If P-flat exceeds 30 centimeters per water, we need to make changes. We can decrease tidal volume or VT to reduce lung stretch, and adjust PEEP or positive and expiratory pressure to optimize oxygenation while minimizing overdistension. Optimal PEEP settings may improve mortality rates in patients with severe. Hello everyone, it's Schematic Med, and today we're going to talk about the initial management of ischemic stroke. The first step is to assess whether there are any symptoms consistent with ischemic stroke, and to perform a non-contrast CT of the head. If the results are consistent with the ischemic stroke, we move to the second step, which is to ask the following questions. How much time has passed since the onset of symptoms or since the patient was last observed at their neurologic baseline? The possible answers are as follows: less than 4.5 hours, from 4.5 hours to 24 hours, and more than 24 hours. When a patient presents within 4.5 hours of symptom onset, the management involves administering thrombolytics, such as tissue plasminogen activator or TPA. Before that, we need to be sure that there are no contraindications. When the patient presents between 4.5 hours and 24 hours, thrombolysis is not appropriate. What do we do when the patient presents after 24 hours? In this case, thrombolysis is not appropriate too. We need to perform standard post-ischemic stroke management, which includes antiplatelet therapy and attempting to identify the embolic source. For patients who present within 24 hours, after determining whether thrombolytics should be administered, the next step is to perform a CTA, CT angiography, of the head and neck. At this point, we assess whether the patient has a large vessel occlusion, or LVO, or if LVO is absent. If LVO is present, we need to perform mechanical thrombectomy. If LVO is absent, we proceed with management as we would for patients presenting after 24 hours of symptoms onset, which includes standard post-ischemic stroke management, antiplatelet therapy, and trying to find the embolic source. Lastly, I want to emphasize one more time that patients who present within 24 hours of symptoms onset should undergo CT angiography regardless of whether thrombolysis is performed. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about the management of carotid arteriosclerotic disease. First, everything starts with intensive medical therapy, which includes aspirin, statin, and blood pressure control for all patients. Then, we need to evaluate to understand if we need and can do carotid revascularization. The question that we need to ask is, does our patient have any symptoms? If our patient does not have any symptoms, the management is different. When we ask a question, do you have any symptoms, and the patient says no, we need to assess the degree of stenosis. If the degree of stenosis is less than 50%, you can see here I try to depict the vessel, and you can see that the occlusion, which is the dark blue side, is less than 50% of the vessel. So this time, there is no benefit from CEA. Once again, when we have an asymptomatic patient and the degree is less than 50%, there is no benefit from CEA or carotid endarterectomy. We will recommend intensive medical therapy with periodic carotid ultrasound. Next, when we have occlusion from 50 to 79%, you can see it's already occluding half the vessel, and we see the smiley face here, which means there are no symptoms. In this case, CEA typically is not recommended, but may be recommended in select patients with low preoperative risks. For example, when preoperative risks are less than 2% or 3%. Next, we can have the occlusion from 80 to 99%. You can see there is only 1% that is not occluded. Here, CEA is obviously recommended. Now let's start to understand what we will do if we have symptoms. It is logical that when we have symptoms, we need to do intervention when we have a lesser percentage of occlusion, right? For the first case, it's the same. When it is less than 50% occlusion, there is no benefit in doing CEA. It doesn't matter if the patient has symptoms or not. Next, here is where the main difference is. When we have occlusion from 50% to 69%, you can see the face is set, meaning it has symptoms. And here it is not 79%. the percentage is decreased to 69%. CEA is recommended only in several cases. Males are more likely to benefit from CEA, and women are more likely to benefit from intensive medical therapy. Next, when the occlusion is 70% to 99%, it is obvious that the threshold percentage is decreased. It is 70%, not 80%. Here, CEA is obviously recommended. And one thing that I want to mention is that not only medical and surgical therapies should be discussed with the patient, but the patient should also be counseled on lifestyle changes to reduce future stroke risk. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about treatment of menopause. At first, we need to assess if the patient has any vasomotor symptoms, for example, hot flashes. If the symptoms are mild, we need to do just behavioral modification. If the symptoms are moderate to severe, at this point we need to assess if there are any estrogen contraindications. The contraindications are breast cancer, coronary heart disease, endometrial cancer, liver disease, or thromboembolism. If these contraindications are present, we need to give non-hormonal therapy, for example, SSRIs. If the patient does not have any of the following contraindications, at this point we need to check if the patient has a uterus. If the uterus is present, we should give estrogen plus progestin. In contrast, patients without a uterus require estrogen-only therapy, for example, transdermal estrogen patch. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about the diagnosis of multiple sclerosis. When we see symptoms like brainstem or cerebellar disorders, optic neuritis, internuclear ophthalmoplegia, and transverse myelitis, we suspect multiple sclerosis. If these symptoms are present, the next step is to understand if we have DIT or DIS. DIT is disseminated in time and DIS is disseminated in space. What does this mean? At first, this can be very confusing. If we have both, means we confirm multiple sclerosis and need to start disease-modifying therapy. If we don't have either of them, no DIT and no DIS, it could be clinically isolated syndrome. What should we do if we have only one of them? Before talking about that, let's try to understand what each of these means. Dissemination in space and dissemination in time are MRI diagnostic criteria. When we look at the MRI picture, dissemination in space means 2 or more brain areas are involved in a non-contrast MRI. We see lesions that are not only just one, they are disseminated in space. Space refers to the brain. And this means that we will have more than one deficit. It is understandable because if it is disseminated in the brain tissue, every part of the brain tissue is responsible for a certain function. So if it involves more than one part, such as 2 or 3 lesions in the brain, it means there will be more than one deficit. Mostly, it is periventricular or juxtacortical white matter lesions. When we're talking about dissemination in time, it means simultaneous active and chronic lesions. We will see this on contrast MRI. We will see one acute, active lesion and one chronic lesion. The chronic one appeared earlier in life, and now there is another new lesion. Now let's come back to the question, what should we do if we have only one of these? For example, if we see dissemination in time, it means we had more than one attack. We can see one active and one chronic lesion. We need to find proof for dissemination in space. For dissemination in space, we need to see 2 MRI lesions that are in different sites. We need to do everything to find the 2 lesions. If we find them, it means we will confirm multiple sclerosis. What do we need to do if we have only proof of dissemination in space? We need to do the opposite. We need to find proof for DIT, dissemination in time, and try to find prior clinical attacks, or ask if there were any deficits previously. At the same time, we need to look for old MRI lesions. If they confirm, we can find the proof the DIT. Again, multiple sclerosis is confirmed. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about risk-based ovarian cancer screening and management. The very first thing that we need to assess is medical history, especially family history. The family history stratifies the risk for ovarian cancer. For low or average risk patients, ovarian cancer screening is not indicated because it is ineffective for early diagnosis or reduction in mortality. The patient has high risk if one or more of the following is present: multiple members on one side of the family with breast or ovarian cancer, male with breast cancer, bilateral breast cancer diagnosed before 50 years old, Ashkenazi Jewish ancestry, and if patient has 3 or more relatives with a Lynch syndrome-associated cancer. Further management includes hereditary cancer syndrome testing for BRCA1 and 2 genes and Lynch syndrome testing. If all of these testing results come negative, no additional screening is needed. We will give OCPs for premenopausal women, and if the patient is postmenopausal, we will do RRBSO or risk-reducing bilateral salpingo-oophorectomy. Especially when we will do hysterectomy during the procedure, we will do both. But if testing comes positive, we should do transvaginal ultrasound plus CA-125 marker level assessment every 6 months starting from 30 years old. Additionally, after childbearing age, we will do RRBSO. Thank you. Bye. Hello everyone, it's Schematic Med, and today we will quickly discuss about oxygen hemoglobin dissociation curve. The middle diagram that has blue color is the normal one. We will talk about left shift and right shift. Left shift means that hemoglobin is not giving the oxygen to tissues. It says it's mine. But if it is right shift, the green one, it means that it gives the oxygen to the tissue. There are several cases that we can have left shift and right shift. It is very high yield and we need to know all of them. For example, left shift can occur when H+ is decreased. When H+ is decreased, it means we have increased pH. Then we can have left shift when 2,3 BPG is decreased. 2,3 BPG stands for 2,3 bisphosphoglycerate. And it is very important to remember when temperature is decreased, hemoglobin dissociation, oxygen hemoglobin dissociation curve is shifted to the left. Additionally, we need to know when we have increase of the amount of the hemoglobin F, the dissociation curve is shifted to the left too. The medication hydroxyurea increases erythrocyte hemoglobin F levels, which increases overall hemoglobin affinity for oxygen and shifts the hemoglobin dissociation curve to the left. One thing that is important to know here that months are required for hydroxyurea to do this. Now let's talk about the right shift. We can see the green diagram. Everything that is opposite to the left shift causes can occur during right shift. So increased H+, which is decreased pH, increased 2,3 BPG amount, and increased temperature. All this can cause right shift. Right shift means that the hemoglobin will give the oxygen to the tissues. Thank you. Bye. Hello everyone, it's Schematic Med. I want to ask you a question. Did you know that when we give oxygen to patients, we can induce hypercapnia? Let's talk how it occurs. We will divide the effects as major, moderate, and minimal. When we have baseline hypoxia, the major effect is pulmonary vasoconstriction. When we administer oxygen, this will dilate the vessels, the pulmonary vessels, and that will divert blood from well-ventilated regions. And we all know that it will increase alveolar dead space, which eventually will increase the PaCO2 or partial pressure of carbon dioxide, the amount of carbon dioxide in the blood. During hypoxia, the hemoglobin affinity for CO2 is increased. When we give oxygen, that will decrease hemoglobin affinity for CO2, that we'll call Haldane effect, and eventually that will increase dissolved CO2 amount. As a result, PaCO2 will again be increased. And last, the minimal effect. During hypoxia, the peripheral chemoreceptors are stimulated, and when we give oxygen, this stimulation will decrease, and minute ventilation will be decreased too. All this will result the PaCO2 to increase. Manifestations of hypercapnia are mainly neurologic and include headache and somnolence. Hypoxia may be absent. Therefore, high clinical suspicion is required to recognize hypercapnia and measure PaCO2 using ABG or arterial blood gas analysis. Additionally, in severe cases, we can observe encephalopathy. That's why maintain oxygen saturation between 88 to 90%. Thank you, bye. Hello everyone, it's Schematic Math, and today we're going to talk about breast discharge evaluation. When we have normal breast examination, which is no masses, no lymphadenopathy or skin changes, and only we have discharge, we need to understand if it is physiologic or pathologic. When the discharge is bilateral, non-bloody, clear or milk-like, and yellow, brown, or gray, we suspect physiologic discharge. This can happen during pregnancy, that's why we need to do pregnancy test, and additionally we need to do galactorrhea evaluation. We need to check TSH and prolactin, and we can observe hyperprolactinemia. If we suspect that the discharge is pathologic, for example unilateral, serosanguineous, or guaiac positive, and sometimes we observe skin changes, this requires age-based diagnostic breast imaging. If the patient is less than 30 years old, sonography, we can add mammography too. If the patient is between 30 to 39 years old, we can do mammography and sonography or sonography then mammography, both of them. And if the patient is 40 years old and older, we will do mammography plus sonography. Here we have pathologic discharge, so we need to do both. So at this point, we may suspect intraductal papilloma, so that's why we need to do both. But if both mammography and sonography are negative, MRI of breast is recommended. Thank you, bye. Hello everyone, it's Schematic Math, and today we're going to talk about management of parapneumonic effusion. Parapneumonic effusion occurs after bacterial pneumonias, which lead to pleural infusion and exudation of fluid into the pleural space. Small effusions in children without respiratory distress can be managed with oral antibiotics and closed outpatient follow-up. One more time, small amount of the fluid plus no distress and no hypoxia. These two should be together. We will give oral antibiotics and we will do close outpatient follow-up. Moderate or large effusions, or when patient has respiratory distress, or when patient has hypoxia, even if one of these three is present, we will do ultrasound. In place of oral antibiotics, we will give IV antibiotics, and we need to do drainage. Thank you, bye. Hello everyone, it's Schematic Math, and today we're going to talk about the management of the penetrating abdominal trauma. Any wound located at the level of the fourth thoracic dermatome, which is approximately around the nipple level, can involve the abdominal wall and abdominal organ trauma, especially if it is penetrating. So, the first thing we need to identify and sometimes exclude is whether there are indications for an immediate laparotomy. What are these indications? For example, when our patient is hemodynamically unstable. Next, the injury presents with evisceration, which refers to the removal or expulsion of organs or tissues from a body cavity. Or when there are signs of peritonitis, which is inflammation of the peritoneum. And another indication could be impalement when a sharp or blunt object penetrates the body and remains embedded. If any of these points are present, these are very serious conditions, and we proceed with an immediate exploratory laparotomy. If these signs are not present, the second step is to perform a local wound exploration. Here, we assess the depth, size, and general features of the wound, and if necessary, we perform imaging. A key question to ask ourselves is whether there is any peritoneal penetration and to assess for any additional organ injury. If the peritoneum is penetrated, the next step is to proceed with an immediate exploratory laparotomy. If no peritoneal penetration is found, the next step is serial abdominal examinations and close observation. Clean the wound and continue observation with serial abdominal exams. Thank you, bye. Hello everyone, it's Schematic Math, and today we're going to talk about postmenopausal adnexal mass evaluation. Ovarian masses in postmenopausal patients are initially evaluated with a pelvic ultrasound. We will assess the mass for malignant features. If we see them, we need to do additional imaging and surgery. If there are no any malignant feature, we see simple cyst, which is not growing, no signs of peritonism. A CA-125 level will be measured, and if it is increased, we need to do additional imaging and surgery. If it is normal, we will observe and do serial ultrasounds. Once again, simple masses with a normal CA-125 suggest that the masses is not growing and is not stimulating the peritoneal tissue, meaning it's likely benign. These are managed with observation and serial ultrasounds. Thank you, bye. Hello everyone, it's Schematic Math, and today we're going to talk about how to approach to postmenopausal bleeding. When a patient presents with postmenopausal bleeding, we can do either endometrial biopsy or we can do transvaginal ultrasound. If transvaginal ultrasound shows us more than 4 mm of endometrium, we need to do endometrial biopsy. If during biopsy we see benign features, we will observe that patient. No further management. The same we will do when during transvaginal ultrasound endometrium is 4 mm and less. If the endometrial biopsy shows as atypia or neoplasm, we need to discuss and consider surgery and give progestins. And additionally, this is very important. All women with postmenopausal bleeding require a pap test for evaluation of cervical cancer. Sometimes during exams, you will see choice that would ask you, would you do a progesterone withdrawal test during PMB or postmenopausal bleeding? The answer is no, because progesterone withdrawal test is not used in the evaluation of PMB because it cannot distinguish between benign and malignant causes. A progesterone withdrawal test is used in premenopausal women with secondary amenorrhea to determine estrogen status. No withdrawal bleeding, this means low estrogen levels. Let's look at the diagrams. We can see here, during follicular phase, the estrogen amount is increasing and the thickness of the endometrium is increased too, right? And when we give progesterone, after that we will see withdrawal bleeding. But in the other diagram, when we can see we have the estrogen amount is very low, the thickness of the endometrium is not increasing. The follicular phase, the proliferation is not occurring, so it doesn't matter if we give progesterone. We know that progesterone will act after ovulation, right? Here, if we don't have the first follicular phase, no withdrawal bleeding will occur. Nothing will happen, right? Because we don't have the first phase estrogen production. That's it. Thank you. Bye. Hello everyone, it's Schematic Math, and today we're going to talk about management of premenopausal adnexal mass. Premenopausal women with an adnexal mass on pelvic examination require further evaluation with a pregnancy test and pelvic ultrasound, which helps identify the mass location, emergent nature, and internal features, for example, benign versus malignant. Therefore, first we will do pregnancy test, and we already said pelvic ultrasound. We need to rule out ectopic pregnancy. Then we will look for malignant features, which is complexity, solid components, septations, calcifications, or increased vascularity. If we see this, we need to do surgery. If we see none of this, we will give NSAIDs, nonsteroidal anti-inflammatory drugs, and sometimes we can give narcotics, but it is very important we need to do ultrasound every 6 weeks until complete resolution. Thank you. Bye. Hello everyone, it's Schematic Math, and today we're going to talk about preterm pre-labor rupture of membranes. The first thing that we need to assess is what gestational age we're in. If it is less than 34 weeks and it is uncomplicated, we need to do expectant management in patient settings. Give latency antibiotics, for example ampicillin and azithromycin, corticosteroids, fetal surveillance, which is a set of tests and procedures that monitor the health of the fetus during pregnancy to reduce the risk of stillbirth. and after 34 weeks we will do delivery. If rupture of membranes is complicated with infection or intraamniotic fetal or maternal compromise or placental abruption, we need to do delivery, intraamniotic infection treatment with ampicillin and gentamicin, corticosteroids, and magnesium if gestational age is less than 32 weeks. If initial gestational age is from 34 weeks to 37 weeks, we can do delivery. We need to consider GBS prophylaxis with penicillin G and sometimes corticosteroids. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about primary amenorrhea evaluation. Primary amenorrhea is the absence of menarche at age of 15 and older in girls with secondary sexual characteristics, for example, breast development, or age of 13 and older in girls without secondary sexual characteristics. The first step in management is pelvic ultrasonography to evaluate the female reproductive tract. Most importantly, we need to see if the patient has uterus. If the uterus is not present, next step will be checking the karyotype. If the patient is 46XY, it can be androgen insensitivity syndrome or 5-alpha reductase deficiency. If the patient has 46XX chromosomes, it means we have Mullerian agenesis. We can differentiate these two by checking the testosterone level. During 46XY and androgen insensitivity syndrome, the testosterone level is increased, but during Mullerian agenesis, the testosterone level is decreased. What about when we have uterus? Next step is checking the FSH level. FSH level can be decreased, normal, and increased. First, let's talk when the FSH is normal. Mostly these patients have normal secondary sexual characteristics, and most likely this is because of the imperforate hymen. Next, when FSH level is decreased, we need to check both things, TSH and prolactin. If TSH and prolactin are increased, we suspect hypothyroidism. If the TSH is normal and prolactin is increased, we suspect prolactinoma. If the TSH and prolactin are normal, we suspect FHA or functional hypothalamic amenorrhea. And last but not least, let's talk when FSH level is increased. Again, we need to check karyotype. If the patient is 46XX, we suspect POI or primary ovarian insufficiency. If the patient has 45X chromosomes, it means we have Turner syndrome. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about management of solitary pulmonary nodule. Imagine a patient coming to the hospital. We performed a chest X-ray for some reason, and we found a solitary pulmonary nodule. The patient will then ask, "What should I do, doctor?" The first thing we need to ask is, "Do you have a previous chest X-ray?" If the patient says yes, we can compare it with the current image. If the lesion is stable over 2 to 3 years, we can confidently say there is no need for further testing, and the patient will be reassured and sent home. However, if there is no previous imaging or if the nodule appears to be growing, further testing is needed. At this point, we will do a chest CT, computed tomography. The chest CT will provide us with several features to assess. Benign appearance. If the nodule appears benign, we will proceed with serial CT scans to monitor its progress. Next, intermediate or suspicious for malignancy. If the nodule is suspicious for malignancy, we will perform a more advanced assessment, such as a biopsy or PET scan, or positron emission tomography. And the last, highly suspicious. If the nodule has very suspicious features with irregular and speculated edges, immediate surgical excision is required. In most cases, after comparing the chest X-ray with old images, a chest CT scan is performed. Following biopsy or surgical resection of the nodule, observation is based on factors like the size of the nodule, the patient's age, and smoking history. We know that smoking history is crucial when evaluating the risk of lung cancer and malignancy. In another video, we will talk about how solitary pulmonary nodule is assessed by size, age, smoking history for malignancy risk. Thank you, bye. Hello everyone, it's Schematic Med, and today we are going to talk about what can cause pulmonary nodules. The possible causes include primary lung cancer, such as squamous cell carcinoma, adenocarcinoma, small cell carcinoma, large cell carcinoma, and carcinoid tumor. Metastatic cancers include melanoma, breast cancer, head and neck cancers, renal cell carcinoma or RCC, germ cell tumors, and sarcomas. Benign infectious granulomas caused by tuberculosis or TB, histoplasmosis, cryptococcosis, blastomycosis, atypical tuberculosis, and coccidioidomycosis. Benign neoplasms include lipomas, hamartomas, and fibromas. Vascular causes such as AVMs or arteriovenous malformations. Thank you, bye. Hello everyone, it's Schematic Med, and today we are going to talk about solitary pulmonary nodule assessment for malignancy risk. We divided the risks to low risk, intermediate risk, and high risk. We will assess the nodule size and margins and patient's age and smoking history. Let's start from the size. It is low risk if the size is less than 0.8 centimeters. Intermediate risk if size is between 0.8 centimeters and 2 centimeters. High risk if size is greater than 2 centimeters. Next, we assess the patient's age. Low risk is less than 40 years old. Intermediate risk is 40 to 60 years old, and high risk is when patient is more than 60 years old. About smoking history. If the patient has never smoked, the risk is lower. If the patient is currently smoking, the risk is intermediate to high. If the patient stopped smoking more than 15 years ago, the risk is low. If the patient stopped smoking 5 to 15 years ago, the risk is intermediate. If the patient stopped smoking less than 5 years ago, the risk is high. It's important to understand how smoking affects the body, and just imagine even after 4 or 5 years of quitting, your risk for lung malignancy may not decrease significantly, so quitting as soon as possible is essential. Finally, we assess the margins of the nodule. Smooth margins indicate low risk, scalloped margins are intermediate risk, and spiculated margins indicate high risk. In another video, we will talk about what can cause pulmonary nodule. Thank you, bye. Hello everyone, it's Schematic Med, and today we're briefly going to talk about the stroke course. When we have embolic stroke, the symptoms are maximum at the onset. During thrombotic type, the symptoms are fluctuating. It can become worse and it can become better. And during hemorrhagic stroke, the condition of the patient progressively worsens. It can worsen over minutes to hours, and ICP, intracranial pressure, increase progressively. Mostly, when basal ganglia or putamen are affected, we can see contralateral motor and sensory deficit, and eyes are looking towards the lesion. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about when to give and not to give thrombolytics. When we're facing the equation, can I give thrombolytics, we need to know this inclusion and exclusion criteria. Inclusion criteria are when we have an ischemic stroke that is coming with a disabling neurological deficit, and the symptom onset is less than 3 hours to 4.5 hours before treatment initiation. Strict exclusion criteria are intracranial hemorrhage on CT scan or a history of intracranial hemorrhage. When we suspect subarachnoid hemorrhage. Important point is to assess the history if the patient has a history of ischemic stroke in the past 3 months. When blood pressure is higher than 185 over 110 millimeters of mercury. When the patient has a neoplasm which is intraaxial. Recent intracranial or intraspinal surgery. Glucose is less than 60 milligrams per deciliter. Platelets are lower than 100,000 per cubic millimeters. The patient is using anticoagulation therapy at the moment. We also need to do laboratory analysis to check INR, PT, and APTT. When the patient is using anticoagulation, the strict criteria are: when the INR is higher than 1.7, when the PT is higher than 15 seconds, and when the APTT is elevated. And lastly, there are some criteria that we need to consider carefully before giving thrombolytics. For example, recent major surgery, recent myocardial infarction, or gastrointestinal or genitourinary bleeding. Thank you, bye. Hello everyone, it's Schematic Med, and today let's talk about the pathogenesis of pulmonary tuberculosis. It starts with the primary infection and the formation of the Ghon's focus, which can spread to the lymph nodes leading to caseation. Ghon's complex will then form. At this point, there are three potential outcomes. Resolution: the bacteria are cleared and scar formation occurs. Next, latent infection: dormant bacteria remain in walled-off foci, which can lead to secondary tuberculosis. In secondary tuberculosis, the bacteria are reactivated and can spread bronchogenically, causing extensive cavitation, which may lead to miliary tuberculosis. And the last outcome is progressive primary tuberculosis. This usually occurs in immunocompromised patients. In this case, we see lung consolidation and necrosis, which can lead to miliary tuberculosis. Miliary tuberculosis is caused by the lymphohematogenous dissemination of Mycobacterium tuberculosis from the lungs to other organs, resulting in micronodular lesions in the lung, liver, and spleen. It is most common among infants and immunocompromised hosts with poor T-cell function, and is often associated with false negative tuberculosis test results. Thank you, bye.